Hello and welcome to this comprehensive lecture on protracted bacterial bronchitis in children. This presentation is brought to you by Pediatric Case Review. Today, we will explore this common yet often underdiagnosed cause of chronic wet cough in preschool children. We will cover clinical presentation, examination findings, pathophysiology, diagnostic approaches, treatment options, and potential complications. This lecture uses case-based questions to enhance your understanding and help you apply this knowledge in clinical practice. Question 1. A 3-year-old boy presents with persistent wet cough for 6 weeks. He is otherwise well with normal growth. What is the minimum duration of cough required for protracted bacterial bronchitis diagnosis? Option 1. Greater than 2 weeks. Option 2. Greater than 3 weeks. Option 3. Greater than 4 weeks. Option 4. Greater than 8 weeks. The correct answer is number 3, greater than 4 weeks. Protracted bacterial bronchitis is defined by chronic wet or productive cough lasting more than 4 weeks. Both European and American guidelines use this 4-week cutoff. British guidelines previously used 8 weeks, but now align with the 4-week standard. This duration helps distinguish protracted bacterial bronchitis from simple post-viral coughs that typically resolve within 3 weeks. Question 2. A 2-year-old girl has had a productive cough for 5 weeks. Her mother describes hearing rattling sounds in her chest. What type of cough is most characteristic of protracted bacterial bronchitis? Option 1. Dry nocturnal cough. Option 2. Wet productive cough. Option 3. Barking cough. Option 4. Paroxysmal cough. The correct answer is 2. Wet productive cough. This specific type of cough is the hallmark symptom of protracted bacterial bronchitis. Parents frequently describe hearing rattling chest sounds when listening to their child breathe. This wet quality is what distinguishes protracted bacterial bronchitis from asthma, which typically presents with a dry cough. The persistent wet or productive nature of the cough is essential for making this diagnosis. Question 3. A 4-year-old boy with chronic wet cough for 6 weeks is examined. Vital signs are normal and growth is appropriate. What examination finding is most commonly heard in protracted bacterial bronchitis? Option 1. Expiratory wheezing. Option 2. Crackles and rattling chest sounds. Option 3. Decreased breath sounds. Option 4. Pleural rub. The correct answer is 2. Crackles and rattling chest sounds. Although parents often report hearing wheezy sounds, true expiratory wheezing is actually rare on auscultation in protracted bacterial bronchitis. Children with this condition typically do not have digital clubbing or chest wall deformities. The examination is often otherwise normal except for the characteristic crackles. This helps differentiate it from more severe chronic lung diseases. Question 4. A 3-year-old with chronic cough has been on asthma medications for 2 months without improvement. The cough is described as wet and productive. What should be considered next? Option 1. Increase asthma medication dose. Option 2. Add oral steroids. Option 3. Trial of antibiotics for protracted bacterial bronchitis. Option 4. Refer for allergy testing. The correct answer is 3. A trial of antibiotics for protracted bacterial bronchitis. A wet cough that does not improve with asthma medication strongly suggests this condition rather than asthma. While they can look similar, the key difference is that protracted bacterial bronchitis responds to antibiotics, not bronchodilators. Always keep this diagnosis in mind when a wet cough persists despite asthma therapy. Question 5. A child with confirmed protracted bacterial bronchitis undergoes bronchoscopy with bronchoalveolar lavage. Which organism is most commonly isolated? Option 1. Streptococcus pneumoniae. Option 2. Haemophilus influenza. Option 3. Staphylococcus aureus. Option 4. Pseudomonas aeruginosa. The correct answer is number 2. Haemophilus influenza. This bacterium is found in 47 to 81% of protracted bacterial bronchitis cases, with most being non-typable strains. Other common pathogens include Streptococcus pneumoniae in 24 to 39%, and Moraxella catarrhalis in 19 to 43% of cases. Polymicrobial infections involving multiple bacteria occur in 30 to 50% of children. Question 6. Bronchoalveolar lavage fluid analysis in a child with protracted bacterial bronchitis shows elevated inflammatory cells. Which cell type is predominantly elevated? Option 1. Eosinophils. Option 2. Lymphocytes. Option 3. Neutrophils. Option 4. Basophils. The correct answer is 3. Neutrophils. Bronchoalveolar lavage fluid in these children characteristically shows intense neutrophilic inflammation, with neutrophil percentages ranging from 25 to 44%. Notably, there is no eosinophilia, which helps distinguish this from asthma. Elevated inflammatory mediators including interleukin-8, interleukin-1 beta, and matrix metalloproteinase 9 are also present, driving the inflammatory response. Question 7. A 3-year-old presents with 5 weeks of wet cough. He is otherwise well, normal growth, and no respiratory distress. What is the most appropriate initial diagnostic approach? Option 1. Chest X-ray and CT scan. Option 2. Bronchoscopy with bronchoalveolar lavage. Option 3. Clinical diagnosis and trial of antibiotics. Option 4. Pulmonary function testing. The correct answer is 3. Clinical diagnosis and trial of antibiotics. Protracted bacterial bronchitis is primarily a clinical diagnosis based on symptoms and presentation. No routine instrumental examinations are needed initially. Chest X-rays are usually normal or show only minor peribronchial changes. The response to a 2-week antibiotic trial essentially confirms the diagnosis, making invasive testing unnecessary in straightforward cases. Question 8. A 4-year-old with chronic wet cough has failed 3 courses of appropriate antibiotics. What investigation should be performed next? Option 1. Repeat chest X-ray only. Option 2. Flexible bronchoscopy with bronchoalveolar lavage. Option 3. Allergy skin testing. Option 4. Echocardiogram. The correct answer is number 2. Flexible bronchoscopy with bronchoalveolar lavage. This procedure is indicated after 3 failed antibiotic courses to identify the specific pathogen and determine antibiotic sensitivities. It is also indicated when specific warning signs appear, such as digital clubbing or chest wall deformities. Additionally, chest CT scanning should be considered to evaluate for underlying bronchiectasis in these treatment-resistant cases. Question 9. You diagnose a 2-year-old with protracted bacterial bronchitis. What is the first-line antibiotic treatment? Option 1. Azithromycin. Option 2. Ceftriaxone. Option 3. Amoxicillin clavulanate. Option 4. Trimethoprim sulfamethoxazole. The correct answer is 3. Amoxicillin clavulanate. This is the recommended first-line oral antibiotic treatment because it is active against beta-lactamase, producing Haemophilus influenza and Moraxella catarrhalis, the most common causative organisms. Alternative options include second- or third-generation cephalosporins or macrolides. However, oral cephalosporins should be avoided in patients with penicillin allergy due to potential cross-reactivity. Question 10. A child with protracted bacterial bronchitis starts amoxicillin clavulanate. The parents ask about treatment duration. What is the recommended initial treatment duration? Option 1. 5 days. Option 2. 10 days. Option 3. 2 weeks. Option 4. 4 weeks. The correct answer is 3. 2 weeks. The standard initial treatment course for protracted bacterial bronchitis is 2 weeks of appropriate antibiotics. Some children may require extended treatment up to 4 weeks, termed protracted bacterial bronchitis extended. The cough should resolve after completing the treatment course. If there is no improvement after 4 weeks of antibiotics, further investigation is needed to look for underlying conditions. Question 11. A 3-year-old child has had 4 episodes of protracted bacterial bronchitis in the past year, each time with positive bronchoalveolar lavage for Haemophilus influenza. What is this child at increased risk for? Option 1. Asthma development. Option 2. Bronchiectasis. Option 3. Cystic fibrosis. Option 4. Primary immunodeficiency. The correct answer is 2. Bronchiectasis. Recurrent episodes of protracted bacterial bronchitis, defined as more than 3 per year, significantly increase the risk of developing bronchiectasis. Haemophilus influenza infection is a particularly important risk factor, increasing the risk approximately 7 times. Studies show that about 1 in 12 children with protracted bacterial bronchitis develop bronchiectasis at 2-year follow-up. This emphasizes the importance of close monitoring and chest CT in high-risk patients. Question 12. During bronchoscopy for recurrent protracted bacterial bronchitis, significant airway collapse is noted. What associated condition is commonly found with protracted bacterial bronchitis? Option 1. Laryngomalacia only. Option 2. Tracheobronchomalacia. Option 3. Subglottic stenosis. Option 4. Vocal cord paralysis. The correct answer is number 2. Tracheobronchomalacia. Studies have shown that airway malacia is found in 68 to 74% of children with protracted bacterial bronchitis. This structural abnormality may impair normal airway clearance, predisposing children to develop this condition. Malacia decreases cough effectiveness, creating a vicious cycle where inflammation worsens the structural abnormality, which in turn perpetuates the infection. For those who want to take their learning to the next level, I invite you to join our Pediatric Case Review community on Patreon. Our community offers all videos organized by system for easy navigation, complete access to our entire video library, and all presentations available as downloadable images for your review and study. You will also have practice questions at your fingertips. If you are interested in subscribing and want more details, please comment below and we will message you with subscription information. Thank you for watching this comprehensive review of protracted bacterial bronchitis. We hope this lecture has enhanced your understanding of this common pediatric respiratory condition. Remember the key points: chronic wet cough lasting more than 4 weeks, clinical diagnosis with antibiotic trial, and awareness of bronchiectasis risk in recurrent cases. Please follow Pediatric Case Review for more educational content. If you have any questions, feel free to comment below. Thank you again for your time and attention.